Thanks for coming to the conversation today. My name is Ashley Pounders. I'm a nurse practitioner with 18 years of clinical care experience. I specialize mainly in optimizing quality improvement initiatives to really help optimize patient care outcomes. So with that, today we're really going to focus on accessing managed and palliative care throughout your journey. So what are we going to gain today? Palliative care, what is it? And what is it not? So I'm interested in knowing how many of you in the room think you know what palliative care is. It's okay if you do not. However, how many of you are like, I have no idea what it is? That's fair. Okay. So it's interesting because I talk a lot about this. I practice in hematology oncology, so this is a common conversation that we have, and it's very interesting how many people, including medical professionals, do not know how to use these terms correctly. And we'll go more into that. But also we're going to talk about the benefits of utilizing palliative care, how to navigate palliative care, and most importantly, and where we'll focus most of our time is going to be on empowering yourself along this journey utilizing these resources. So what is palliative care medicine? So for all of you in the room who raised your hand, this is exactly what you thought, right? So what we're going to do is, palliative medicine focuses on improving patients' quality of life by reducing suffering from symptoms and the stress of a serious illness at any age of the disease. And this is a really important point because I think a lot of people do not understand what optimizing quality of life means, and also across the entire journey, because this is very holistic, this is very a continuum. So what was quality of life 5 years ago might not be what you think quality of life is today. So we're going to work on how to navigate that and how that changes as your circumstance changes as well. So what palliative care is not? And I always lead with this because a lot of times people shy away from having this conversation because they're like, oh, I don't want to talk about palliative care. It means I'm going to die. It means that we're giving up. It kind of says we don't have any more hope left for you, right? And so that is such a huge misconception, and even medical professionals utilize it inappropriately. And so it's our job to all work together to, number one, understand the correct terminology, which it is not that. But what it does do, and this is where the misconception kind of comes in, is that palliative care is sort of like this pivot of going between medicine and aggressive symptom management versus if the time comes where we do need to shift and focus more on end of life, palliative care is who can actually bridge that transition. And so it is not only that, and so a lot of times palliative care goes highly underutilized because of that misconception. And this is where in the rare disease space, especially with refractory epilepsies, is that this service line has not really been implemented as much because of the lack of understanding. Did I go the wrong? Hang on. Oh, no. So I'm going to circle back to this slide because, again, I really think that as we go through this workshop and as we start to learn more about what this is and how we can truly apply it to your life, is really understanding what quality of life means to you. So what is quality of life? I like this definition. It's by the Oxford Dictionary, and it says it's the standard of health, comfort, and happiness experienced by an individual or group. And a group can be a family dynamic, a family unit, it can be your bigger circle, it can be whatever you want to define it as. But essentially it is providing the health, comfort, and happiness. And so when we use palliative care and when we just talk about how to get help, like what does this journey look like, a lot of times we don't stop and really ask ourselves the hard questions. What is my quality of life? What do I want that to look like? So today we're going to work through on how to really optimize that for ourselves. And the reason why I take some time to really call the quality of life out is because if we don't start unlayering like kind of what you are processing through the journey, you kind of get stuck in not being able to process certain things that come up. It's a very complex journey that you're on. And when you can't process it, you kind of get stuck and you're not optimizing your own quality of life. So palliative care really focuses on these 3 different pillars, and so you guys are all your own experts in the medical support. I know there's been a lot of sessions already that really focus on medical support. I think here is I love coming to family conferences because seeing you all interact with each other is pure joy. You see the happiness that comes out of you guys, your kids. It's just, as somebody who is not impacted by this rare disease, but only on the medical side, it brings so much joy to my quality of life of seeing how all of you all really, really just empower each other. You're there for each. It's a beautiful thing to witness. And so obviously that's part of palliative care is community support. And that's why I think the LGS Foundation is an amazing foundation that really tries to put that together as much as possible for everybody. And then family support. So again, palliative care is the family dynamic. It's the big unit. But also underneath all of these categories, it can be subcategories. And one of the things that we'll focus on a lot today is, I always want to say individual support, because I think as a caregiver, you oftentimes keep pushing that to the back burner because there's always something that comes up, right? And so we're going to take some time to really, really focus on that. Let's see. All right, so and then palliative care provides choices to your goals and wishes while you're ensuring your medical team is informed along the way. So this is the only medical component that I'm really going to hit on today, because another component that the palliative care team usually does is they make sure all of your doctors are informed of what to do, of your wishes and your goals. I think there's a lot of times where you don't necessarily have a quarterback of all of your care. You might have your epileptologist who's really kind of leading that, but they're not really the expert on all the additional things. You might never have been asked by your epileptologist or your neurologist, how are you doing today? Or, how is life really going for you? Because usually you're focusing on your medicines, the different tests, all these different lists of things that you need to do. You really don't focus on the actual support. And then a lot of times some people don't want to bring it up. That is something that I've also seen too. They don't want to talk about what I always say is the elephant in the room of what's not going well. What's really bothering you. A lot of times people will say, I can manage the epilepsy component of this, but it's this behavior, or it's this, or it's that. And a lot of times folks are just embarrassed to talk about it, or they don't feel the need to want to bring it up during that time. And so that creates a barrier in your own quality. So I'll go back to this one real quick. So another point here is sometimes you don't know what you want, right? I think there's so much that goes on in your journey that sometimes it's hard to pause and just really understand what it is that you want, and that's okay. One of the part of the workshop today is understanding that it's okay to not know what you want. It might be okay to start with what you know you don't want, and that's okay too. There's nothing wrong with that. Okay. So here are some of the signs that we work a lot with in palliative care. And to get palliative care, part of your care team, one of the things that we have to do on the medical side is kind of really, how are we going to help with aggressive symptom management? In the epilepsy space, I've heard sometimes where palliative care teams might say, oh, well, you're going to have epilepsy surgery, so that should, fix your epilepsy. And you're like, okay. Yes, but there's a lot of other complex needs that are needed in somebody who has, a rare disease. And so with having a serious neurological disorder, these are the main focuses that palliative care can also help on the medical side of it, that can really help, that often do not get talked about in most doctor's appointments. So how do you get palliative care? So palliative care is a team of, it's a physician, nurse practitioners, physician assistant, nurses, social worker. The list can really be as long as it needs to be. It's very unique to the individual and the services that they need. But it's just a referral, like if you were to need to see a cardiologist by one of your healthcare providers, and then that team sort of starts the process of evaluating the need for these services. Once they get all the information, then this is when you would actually meet with your care team right here. And then once it is, approved and you have them part of your care team, the main thing that you'll have is an ongoing support. I always think that they're sort of like become the quarterback because they really are not specific to one organ, which I know sometimes we are like, oh, well, I have to go talk to the cardiologist about this, and I have to go talk to the, the lung doctor about this, and the neurologist about this, but no one else is, but they're not really talking, right? And so palliative care is a team of specialists that say, we're going to go talk to all of them, and we're going to make sure they understand what you want and what your wishes are. And so that's why it can be really helpful having them on board. Okay. So I know I said a lot about palliative care, and it's really just a service line that helps. It's another barrier, or it's another, a barrier to help you. But I say all that, and this is why I'm shifting the conversation a little bit, is because like with anything in medicine right now, palliative care has historically been utilized a lot for like oncology patients, those outside of the rare disease space. And so this is, in the last 10 years, has been a huge shift in rare disease space to utilize palliative care for complex neurological disorders. And so I say all this because I've given this talk before and had multiple phone calls and emails like the week later of, I called my palliative care service team and they said that they didn't want to help me. And so it's like, hold on, that's not everywhere. So palliative care services, they'll be dependent upon the state and your region. And so it's not available everywhere. So I know it's a little disappointing, but it's actively growing. There is a lot happening in the palliative care space to really improve this as a resource for those who have complex care and refractory epilepsy, because they understand the huge burden and the barriers that you guys face daily and the services that you need. So hopefully you can look at oh, that's really small. So there's a website that you can actually put it in, and it's capc.org, and you can actually put in your zip code, and it tells you what services are available in your area. And so don't be disappointed if, go ahead. Sure, it's capc.org. Yeah, so don't be discouraged if there's not a service in your area. It is growing very rapidly, and so it will be available hopefully sooner than later. But I don't put it past the rare disease community to be able to expedite this, and you guys are historically trailblazers, and this is nothing new to you. So I think that understanding that on the front end of this conversation is helpful, so it's not misleading if you were to want to have this service available for you all. So the reasons why, it's again, access to palliative care resources locally, regionally, statewide. The medical professionals, so to be a palliative care provider, you have to have additional training and certification. All of the team members, so the nurse practitioners, the nurses, social workers, they all have additional training to help so that they can help individualize the needs and resources that you need. The quality standards and research. So again, this is just an untapped area in the palliative care space on how to optimize this, but I think I was mentioning to somebody earlier, like, we don't like to recreate the wheel. So we have these supports and resources available in the oncology space, and it's really no different on how to just reuse those same method and approaches for the rare disease space. Clinician skills, and then public and clinician awareness. So again, half the battle is if you were to say to your neurologist, hey, I really want to talk with the palliative care team, and they'll say, why? We're not at end of life. Like, red flag immediately, like, they just don't understand the benefit of utilizing another additional support services that can really help optimize the quality of life and help reduce the barriers that you guys are experiencing along your journey. Okay. So we're kind of pivoting a little bit into putting it all together. Let's see.
Pivot! Pivot! Pivot!
So I like playing that video clip, one, because I think these can be very tough conversations to have, and humor is the best medicine in my opinion. But also, it's just so classic of everything that I feel like you have to deal with complex situations. You're constantly pivoting. You still have to get the couch up the stairway, but how are we going to do it? And this one doesn't go as long, but each individual in this scenario has a very different opinion of how to happen. And one person's trying to lead it, the other one's really struggling, the couch is about to fall over them, and then somebody's in the background just watching it, right? That's kind of very applicable to life, right? So I like to kind of start with this so that way we can kind of focus on moving forward. And so, let's see. Yeah. So one of the reasons why I like to kind of pivot is because when you utilize palliative care, you have to know the resources that you potentially want. You got to understand the barriers that you're experiencing. A lot of times in the rare disease space, caregivers have never really had the opportunity to stop and pause to understand and process the grief that they experience, because you go in straight survival mode. You don't have time to stop. You go 2 feet in nonstop. You want to talk with me, buddy? Come on. He's like, let's go. And so I always like to have, especially when this conversation is new to a community, is to kind of stop and pull back. We could go full throttle into all the different things that palliative care can provide and all the different things, but the reality is that those conversations are really hard to have with families when you don't know where you're at and what you have done. So there's a lot of things that we can control on this journey, and there's a lot of things that we cannot control in this journey. And so it all starts with kind of where you are in the whole grief cycle. And so I like to say, grief is a friend and a foe. And the reason why I say that is because without love, there would not be grief. And so we try to put it in a box, seal it up tight somewhere, and we put it away, and we don't really want to talk about it. And the reason why that is problematic is because undealt grief deals with a lot of collateral damage, a lot of traumas. Marriages, relationships, friendships, work, your faith, all different things are really impacted when we don't start and just look at grief and say, hey, you suck, but let's do this. And so what is that? It's a continuum of these different cycles. And the thing, especially on the LGS journey, this is a continuum. You don't graduate. You don't get to an end point. It's a constant circle that you will experience. Milestones, a lot of people don't talk about, milestones are huge triggers for several people. Graduating kindergarten, graduating college, my kiddo getting a driver's license, your kiddo will not get a driver's license, marriages, all these different things that our friends and their kiddos are experiencing, it looks different. And so sometimes knowing that can be a trigger and you're not sure why you're getting all tensed and angry and all of that, it's because you're grieving, that you're not experiencing what you thought you were going to experience when you had a child, and that's okay. It's okay to acknowledge it, but you can't do anything about it until you at least acknowledge the fact that that sucks. And that you acknowledge it, but you can't get stuck in it, and then you gotta get out of it. And so this is really where the grieving process starts. So again, this is just, the grief is a continuum. What you can do is you focus on controlling the things that you can. And that can be really hard. That can be things like your attitude, your actions, behavior, what you eat, how you speak, the boundaries you set, how you react, who you follow, who you don't follow. I think social media is such a huge thing nowadays, and a lot of times that can actually drive a lot of anxiety for families. And just because that's not what you're gonna do, or I always pick on mother-in-laws. I don't have a mother-in-law, but I don't know why, but it's it's what you want, not what somebody else wants for you. And that's okay. You can control that. And then challenge your need for certainty. I think this goes back to the grief of just anxiety that comes along and the bargaining that comes along with grief, is that sometimes it's like, but I need to know. I have to know the plan. I have to do this. Like, I has to do that. And unfortunately, in a lot of complex journeys, you just don't get to know that answer. And learning to kind of let go where you can is beneficial. Focus on being present. Again, I think this number 2 and number 3 kind of go hand in hand, because if you're so focused on making everything has to be this, then that, then this, then that, then this, you really start to lose focus on the present moment and really enjoying kind of where you are. And then reduce your anxiety and stress. I know I always get a giggle in the crowd when I say that, because it's like, that's cute, but yeah, no. But by being present and limiting those distractions, right? Like, if we're constantly exposing ourselves to things that heighten our anxiety, that heighten our triggers, then it's harder to just reduce our own anxiety. And a lot of times we don't talk about this either, is the voice in your head, that person that talks, they need to shut up sometimes too. And they need to change the narrative that they talk, because it can be very, very debilitating. Other things like focusing on meals, sleep, exercise, nutrition, meditation, all these things, and we'll go over them more in the paper. But again, it's just really knowing that grief is here, but we learn to live with grief versus thinking we are going to escape grief. Because again, without love, there would be no grief. I think that was an extra slide, but I can talk, so we can go through it some more. Where do you start? So again, when I get phone calls sometimes from families, or I have a new diagnosis, they'll say, I'm so overwhelmed, I don't even know where to start. Or I don't know, I've been on this journey so long, I don't even know what I don't know anymore. I don't know. It's just that, almost that numbness that kind of comes over you. And that's okay. Accepting to start where you are is very, very important. Be kind with yourself. Again, that voice in your head, they can be a jerk. Sometimes you just got to tone them down. You got to tell them to stop. And letting go of being perfect. I strive for consistency, not perfection. That's really hard. That's so easy to say, but so hard to implement at times. I know routine, that's not routines either. I've had that conversation too. So being consistent is a routine, but having a perfect routine is not always healthy either. Okay. So I'll go through some of these a little bit quickly, because most of you in the room know what a caregiver is. But I think the bottom line here is knowing that caregivers are experiencing way more responsibility and stress than they have in the past. And here I'm going to go through. Oh, I think I have these out of order. That's okay. I'll come back to that point. But caregiver stress. It's at an all-time high. And again, a lot of the statistics that are out there are all pre-COVID. And so it's only has gotten worse since COVID, because all of you could probably write a book on how much changed with COVID. Resources were lost. And then some of them were really hard to get back after COVID. So that really impacted quality of life for so many families. What is caregiver burnout? I put this slide in here not too long ago because I think I was surprised how many caregivers didn't know what burnout was. Because and the reaction I got was, well, it doesn't matter, because what am I going to do about it? Like, I still have to do this. I still have to do that. I don't have this resource to help with that. And so it was really puzzling to me to kind of be like, okay, I get that. And so, but what does that look like? Or you have the complete opposite, right? You have the person who looks like they have it all together, and they're just handling it. And you just look at them in awe, and you're like, how are you doing all the things that you're doing? And it can just all be how we, handle stress, number one, but also realizing like what the symptoms are. And they can be physical, they can be emotional, they can be behavioral. So if you want, you can take a picture of this, because I didn't actually print this, but this will be really important when you kind of go through the caregiver zone of where you're impacted by. Again, this is as a continuum. So where you are today might not be where you are, in 2 years from now. And how you handle it might be different than how your significant other handles it versus how a grandparent that's helping manage care, like all of the things, right? Siblings even. Siblings can also have a sense of burnout. Theirs is not technically a caregiver, but there's still stress that is added to siblings. And so these are just recognition ways of really how to be aware of where you're at. So these are the stats that I kind of go over. And I guess time is in the eyes of the beholder today. So I'll just go through some of these that I think are really interesting. But again, the bottom line here is that most caregivers are not really asking for help. And I think this is more women have paid jobs in addition to a caregiver role, 3 in 5. So again, all these stats were pre-COVID. So again, they're probably way higher. And also what we don't talk about a lot is not only might you be a caregiver for your child, you might be now a caregiver for like a parent. And so you're a dual caregiver, and that is extremely burdensome and very difficult to navigate. So caregiving children. So again, this was a study that was done back in 2017. And again, it showed that caregiver mental health was impacted by 84%. Pain was one of the most common reported symptoms. And then sleep disturbance was also. It's not, for any researcher or someone who really looks at stats, like it's not really comparing apples to apples in all of those studies, but those 3 things were looked at across the board. So some of the studies don't look at it, so that's why the stats to it looks a little weird, but again, the ones that did look at it, it was pretty high. Again, so anxiety, or caregiver anxiety and depression, this is a lot of what was reported. So a lot of people don't talk about it. Caregivers don't talk about it. They don't talk about they might be really anxious or depressed. And these are the reasons why. Out of those studies, pulled out why they don't want to talk about it. Because they overwhelmingly, thoughts of judgment or showing weakness were the 2 main things that were constantly talked about. And then here's how the depression fell as why they felt depressed. Again, this is going to be very different to each person. I always like comparing women and men in studies because we all just handle stress so differently. I always giggle and say, how many of you non-huggers in the room married a hugger, right? Because you're just different, right? I'm a non-hugger and my husband's a hugger, and I'm like, give me 5 feet. Like, especially when I'm stressed. And why all this matters is because, love languages and how you interact when you're stressed can really impact relationships regardless. And so these are just the differences of why women didn't go get help for stress. And so women are over here and the men are over here. So I would say overwhelmingly men are overcompensate by either overworking or being absent in the home from the studies. They might have a hobby that they go do, consistently, but it's disengaging from home responsibilities. And then women just don't speak up was the main kind of takeaway. They just are very silent and they don't talk about it. I promise you this all is going to tie back in. So, and then again, this is all stuff that you are very aware of, but the burden of caring the stress or negatively impacting the quality of life is all of these different symptoms. Fear of the unknown, navigating medical emergencies, like that's such a huge, I think one of you in the audience was sharing your story about, your child having a seizure on a plane and you were having to calm the stewardess down. And it's like, yeah, you are the expert in the room a lot of the times. And so that's still stressful. That's still really hard because that impacts future, like what you do next with those experiences. New symptoms, waiting for new symptoms. I know depending on the rare disease, sometimes it's like you feel like you're walking in a landmine. You don't know when the next symptom is going to happen or the next thing is going to happen before you have to start, with something new. And so it's very challenging. The neuropsychiatric problems, so this is like behavioral issues, impact on the career and family routine. Okay, so we're shifting back, so I would play the pivot just because it's a fun clip, but we're pivoting back. So now that we understand a little bit more about kind of just basics of what palliative care is, and really what you have control over in all of this, how we can tie that back into what we're going to plan on doing next. So as we move forward with going through the worksheet, I think it's really important to just really focus on health, the standard of what health means to you, and comfort and happiness as yourself, because if you're here by yourself or go back and talk to a significant other, it's going to be really interesting to see where the differences are. And I think it's a really important point to call out. Okay, so I think everyone has the sheets. So I created this for the TSC Alliance a couple years ago, basically because of all the calls that we are having, because you would get called, and again, where I think I said it earlier, where that I don't know where to start and I don't know how to ask for help. I'm just overwhelmed, right? And so I did all this research to try to find, well, how do we start helping these families now navigate when, palliative care isn't a resource available for everybody in every, city, state in the U.S. at this point. This doesn't matter as far as, don't worry about the website. I did want to call out another thing here. But if you go to the TSC Alliance website, there is an advanced decision-making section, and there's an advanced decision-making section, and in it there's an acute decision-making. So for those of you who are ready to have a more in-depth conversation or just start to think about it, I will say after 18 years of basically doing critical care, most of that, the time to have those difficult conversations should never be in the moment of the difficult conversation to have to make it immediately. It's very traumatic for that caregiver. It is hard for everybody involved. And so but it's difficult, and not everybody's ready to have those conversations. So it might be a good open to, what can I do? Like, how does that process start, and what to ask for, when to ask for it. The advanced decision making is something that you can think of over time. The acute decision making is more inpatient, something's really going on, and I might have to make some tough decisions. And so those are two options. We're not going to really talk about them today, but I did want to call them out because I do feel like they're commonly asked for. And again, why recreate the wheel for one organization to another? Just it's already out there. Yeah, that's okay. Okay, so we're going to jump in here. So I always call this finding your caregiver zone. So we created 4 different areas. So thriving, surviving, struggling, and crisis. I call this the Instagram column because nobody in life is really thriving at all times, right? It's just not realistic. But these are the most important. So it's the symptom burnout that I had you guys take a picture, these actually align. So this is the y-axis and this is the x. So if you go downwards, it's how your emotions, your focus, social, appetite, sleep, daily activities, and self-care. And then how each of those are going to play out across the board, right? So a new diagnosis or an acute issue happening, you're probably going to be in crisis, right? The goal is to try to be in a mixture of surviving and struggling and hopefully some areas of thriving, right? The goal is not to say I'm going to be all areas here or all areas here, or we definitely don't want all areas here, and we really don't want all areas in the crisis zone. So again, like grief, it's a continuum. So check base, like kind of checking in with yourself. I think it's really hard when you are going through so much emotionally to make the reality objective. And by that, by meaning, it's easy to say subjectively, I'm really overwhelmed. I feel like the feelings, right? Subjective is I feel. But objective is saying, you know, I have not slept 3 nights this week, more than 2 hours, right? It's making it something that you can recall to say, okay, so this is why this is really helpful, because when we're so overwhelmed with the crisis that we're dealing with, it's hard to pull out of and make it more of a reality to say, okay, I'm not struggling in all areas, or I'm not in crisis in all areas. I'm surviving here and I'm thriving here. So I can continue to maintain that while I might need to shift more time over in another area, right? So that's the goal. So I like to always try to really explain that, so that way you don't try to think you should be here. If you're here, call me, because I want to know what you're doing, because that'd be great. But then it's like, how do I, or you might say, I have so many people that ask to help me, but I don't know what to tell them. Or it could say, my mother-in-law is always coming over doing the laundry, or taking this, the other kids out for dinner, but all I really want her to do is do the laundry. It's not being able to articulate your needs to where you can actually get some help. And so that's one of the 2 main reasons why I created this, was to really try to help focus on where we can do that. So here's an example. I don't have a blank template. That's a really good idea. We can for sure try to get you guys one, and so that way you can fill it out. But this is just an example. So the first sheet you have is finding your caregiver zone, which was the slide that I just showed you, and this is how to help me worksheet. So this is where we're kind of going to go through, and this is open, like I want to make sure any questions, like I want this to be organic conversations, clarifying anything, but I didn't put thriving in there solely because if you're thriving, you'll figure that out, but really just to realistically say, let's get out of this zone, how do we get here, and then how do we get here? And when you process grief, understanding milestones, understanding your triggers, you can also start to proactively help yourself too. So if you know there's a high school graduation and your kid might not be graduating, like that's hard, that's just hard. And so you might say, I'm prepping my mind that I might be moving from here to here. And you can go ahead and start proactively putting things in place for yourself to where you can kind of ease through some of that. So it's open for discussion. I'm here to ask or answer any questions, and we can go back to other slides, or if you want me to elaborate on anything else, I'm happy to do so. But this is the takeaway, is I really want you guys to kind of self-reflect, like where are the main areas that you are feeling like you're in crisis, and how can we work to work out a plan for you to put something down on paper. You don't have to do all of them, but just, a few. So, questions? Yeah.
So, I guess my question, so we talked about palliative care.
Mhm.
Can you hold on a second? I need to use the mic because they're recording. I'm sorry. Thank you.
So my question is, since we've talked about palliative care and caregiving, and kind of breaching the 2, so my son, not this one, my 9-year-old is LGS, and he is on palliative care in Arizona. which we've really found useful. But we've also, I would say that has been more him-focused instead of family and caregiver focused.
Yep.
So I guess my question is, in your mindset, if you were to design something perfect scenario, what would be there to bridge that gap between those two aspects of the medical palliative care and the caregiver needs?
Yeah, so I would say first step would be use something like this, and you should bring it to your palliative care team to say, hey, as the caregiver, let's work together on how to help me with this issue. So that would be the first step. The second step, is when you can give some empowerment to yourself in some of these areas, then you might not need additional resources that the palliative care might think. Like sometimes palliative care, depending on the palliative care team that you're working with, they might think, oh, they need somebody to, we have to find somebody to come to their house, like a resource that, then it gets into like, do we have any needs for this in the area, or your insurance doesn't cover it, sort of thing, to, no, I just want to talk it out with you. Like, these are the issues that I need. And they're really good at sort of helping walk through something like this. This just brings it out on paper. I think, if you don't mind me asking, was it inpatient and then you shifted to outpatient? Outpatient. Okay, that's awesome. What state are you in? Okay, very nice. And so, yeah, I would just bring it to them and then help them merge it because they should be able to help with that. Yeah.
I have a question for you. Can you describe for the room the difference, and only because I'm from Boston Children's area, the difference between complex care team and a palliative care? Because I almost feel like the palliative care is built into my son's complex care team design.
Yeah, so that's going to depend on where you're at. Some locations, their complex care team is the palliative care team is actually part of that team. Other places, it is not. So step one would be to look to see who is part of those care teams if you have them. Unfortunately, not all places even have a complex care team. But that is one of the biggest things that the Palliative Care National Alliance has been pushing, is that there's palliative care incorporated into the complex care teams. So there's not a huge difference depending on where you're at. If it is, the differences that I've seen, and that would just be subjective to my experience, is if they are separated, complex care is more of like an internal medicine, like a med ped, so somebody who is trained to do pediatrics and adults. They are great part of the team, but they don't have the additional qualifications that a palliative care specialist would have. So if you can't get palliative care, I would strongly see if there's a complex care management team in your area, because they would be the second best to kind of help you. And that is actually something that is also on the rise because of, I think the thing that I didn't mention earlier is, why all of a sudden are we talking about palliative care? It's because of the research. It's because of all of those gaps that let's see, let me find the slide real quick. So all of the gaps that are currently in just this specialty are because of this, the neurologists, all these other experts have excelled. Our kiddos are living longer with rare diseases. We really have high quality and standards for different, medical conditions. Our medical professionals are getting more trained, more exposure, more awareness to some of these things, and the research is constantly growing. And so there's a reason why things are different from 20 years ago, 50 years ago, to where we are now when we get somebody who's diagnosed with a rare disease. So it's kind of that continuum of even medical care, right? Like the advancements of one have now led to a little bit of a barrier in the other, but it will catch up in time. But that's the reason why a lot of times this space has never heard of palliative care. So I hope that answers it. Most children's hospitals have a complex care team. They should have a palliative care team, but they might not all be combined. And adults, so if you have an adult, a lot of times the complex care team is ran through the pediatric hospitals.
So for the caregivers that we don't have any idea about this. So I have never searched anything about palliative care or anything. But I am in the right room because from the list of things that you have in there, the only thing I don't have was nauseous. So yeah, I'm in the right place. But who do I bring this up? You know, do I talk with my epileptologist? Do I talk with, I don't know, because I searched in the webpage that you just said, and I am from Maryland. There was nothing in there, at least for home. Mm-hmm. There was in hospitals, but it says Children's Hospital. So it's like, I go to the Children's Hospital and I ask for the palliative care division or something, department.
Right. What state did you say you were at?
Maryland.
Maryland?
Yeah.
Okay. So there are services, you can start with your epileptologist. Now, whether or not your epileptologist is aware of which resources are available is a whole nother story. So you could always start there. You'll need a referral, so you can start there. You can, if you're going to a pediatric hospital, you can ask to speak to the child life specialist. So they are great resources to knowing what other, like how to get implemented into something else. They would probably already know like who is like complex care management. So they could be like a resource to help you find who you talk to next, because you would still need a referral. Most children's hospitals' websites would probably have the palliative care team like listed, and they might have like, call for questions or, email us. So you could say, like, just try to reach out to them to see. A lot of them have intake coordinators that kind of help with these random questions that they would just get without a referral. That, or if you already have like a really good primary care or a pediatrician, they might be aware. So those are the three places that I would at least start looking in your area. I think Maryland has some though. I know. I'm pretty sure. Yeah, we'll see. Yeah, yes. And most palliative care, if they do inpatient care, there's usually a resource for them to do outpatient. So it might only look like they're inpatient, but they have services for outpatient too. Social workers are also amazing. They really know who to contact as well.
So one of the biggest challenges that I've had, so my daughter does, I think, see like a complex care team at UCSF, and they've been amazing for like even coordinating amongst all the specialties and booking appointments and like helping us get coordination between them, as long as it's all at UCSF.
Yeah.
But another area that like I often struggle with, and I wish that there was a service that could like deal with insurance, deal with coordinating care across institutions. Is there anything like that like a palliative care team would know about? Or, because I feel like that's such a huge burden on us caregivers in the LGS community. Like,
right.
Even just ordering prescriptions and waiting for the deliveries and all that stuff continually over and over again.
Right. So, and UCSF is San Francisco? Okay. Sorry, I just want to make sure my geography is right. So California is its own like country, in my opinion, when it comes to insurance. I would say that if you have like Medi-Cal or something as a secondary, do you have a caseworker? Are they helpful? Okay. So usually they should be the ones to help coordinate that. Whether that happens or not is always a different story. The palliative care teams would not be able to do through multiple institutions. I know a lot of people have to travel across state lines. That's a huge barrier. I don't know of any palliative care team that can help truly coordinate it, but what they could do is help with the communication aspect between one team and another team so they can communicate, but as far as the coordination goes, that would probably still fall on the caregiver. I really wish there was a better answer that I could give to help with insurance, but unfortunately, there's not one that would be standard that I'm aware of. But it is a horrible problem that I hope if there's industry here, maybe they can help with starting to make things like if they have an assistance program, or you can be assigned to a patient assistance rep through whatever medication you have. A lot of them have direct lines to a support person. They're usually really helpful. And there should be a direct number. So when you interact with industry partners when they're here and you're using one of their drugs, ask them who their patient advocates are, because they're going to be the ones that are going to answer, and they're going to be able to get things resolved internally on their end, even if it's a shipping issue or like this insurance is now denying it. So yeah, they're the ones who are going to get down to the bottom of it. So knowing those people is really helpful. I know that doesn't make any less work for you, but it maybe help with a few extra phone calls and 3 hours on hold, because I know you guys, yeah, it's a full-time job just doing that. Yeah.
So I guess this is more of a statement than a question, so I'm sorry about that. But so we've had palliative care for about 2 years now, and we were referred to outpatient, and I was scared to go on it at first because I thought that was kind of like the beginning of an end. Like that's what I felt I was agreeing to.
When you, just to clarify, when you accepted palliative care?
Yeah.
Yeah.
Yeah. And I found that it actually decreases my fear. It helps me know that there's someone there who is willing to talk about the hard things.
Yep.
I find a lot of practitioners in medicine want to fix things
Yes.
versus quality of life decision making.
Yes.
And so that's been really reassuring. And then I would say as well, we have documentation, procedures in place. If, for instance, my child died in the middle of the night,
Yep.
and I have other minor children in the home,
Yeah.
a very real fear is that my other children would be removed during an investigation or
Right.
something of that sort. And knowing that there's paperwork, there's doctors, there's
Mhm.
things in place that will back up his condition
Right.
and protect our family
Yeah.
in that unforeseen circumstance,
Right.
it gives me a lot of peace of mind that I
Yes.
did not have beforehand.
Thank you. That's
Yeah.
so helpful to share that.
So that's not a question, but just a testimony
Yeah,
of the power
yeah.
of
No, I
this.
think that is exactly why palliative care is becoming more of a normal conversation in rare disease spaces, because there are horrific stories of your fears, right? There's a reason why you have those fears, is because you probably have heard of situations before, right? And again, that's why I kind of did highlight that, acute decision-making and the advanced decision-making, because it is so hard to have those conversations in the midst of that crisis, right? It's not a conversation any of us want to have, but I can assure you it's not a conversation you want to have when you're having to make a decision. So thank you so much for sharing that. It'd be interesting to know and share with your peers too about, I'm interested to know, and if nobody else has a question, like, did your medical team bring it up to you, or did you have to ask for it? Sure.
Yeah, so our child participates with Phoenix Children's Hospital in Arizona, and he was part of the complex care clinic here prior to, where that was his primary pediatrician. And my son, a couple of years ago, had a pretty significant seizure increase and physical decline over a period of about 4 months. We managed it outpatient with neurology and pediatrician and all that type of thing. And then through community connections with other parents with similar children who were part of palliative care, who recommended it, as well as our pediatrician, brought it up and then made that referral outpatient. It did take about a year, so maybe it was 3 years ago. I might get my timeline off. It took about 9 months to a year to actually have that first palliative care appointment.
Okay.
And I think that was because it was an outpatient referral. That took a little longer, but I'm really glad that we have that in place.
That's
so.
amazing to hear that they at least, helped facilitate that.
Yeah.
And it's a good point, because I think, unfortunately, hospitalizations are not abnormal for most of you. And sometimes to prevent some of that is asking for palliative care if you're in the hospital. Maybe if you've had, like if there's a status and you're in the ICU or intubated, it's okay to ask for those services while you're inpatient, just to say, you might have to reassure your medical team that, to your point, like it's not the end, but it's like, hey, I just want to have a talk with them, just sort of like make sure we're all on the same page. Like that's the approach I would take, because no clinician is going to say, no. If they do, I'd be like, they should always accept it, but it also gets you established with the palliative care team, and then they can transition you to outpatient. So you're not a new patient waiting for an appointment. You're already being established while you're in a hospital, and then it can carry over while you're in an outpatient. So thank you for bringing that up, because that is another alternative when we're still kind of lacking, a proper, referral method at this time. Yep. I know this is such a personal thing to think about, but I hope that having some of the examples written out kind of will help you all just sort of think about it and kind of process where you're at. And again, just really optimizing what quality of life is. I think it's always in the eyes of the beholder. Hope is subjective. Hope of what you have today might look different from where you are in 10 years, but I always say that's not ever giving up. Your hope just shifts. The focus changes. And I think once that becomes the acceptance, I think it becomes a lot easier to find peace and kind of just, I wouldn't say acceptance, because you don't have to like it, but you do have to acknowledge it. Yep. Is there any other questions? Or anything else, anything else you all want to talk about? I think we have time. I'm not sure exactly where we're, that's also subjective. I know it's a hard conversation to hear, but I appreciate all of you guys taking your time to at least listen to it, to kind of go through kind of what it is, and just at least if it just plants a seed, that's all. And that if that's all where you're at, then that's great. And I hope that the worksheets really help benefit you all. And I think there's plenty of copies, so I'll give them to the staff, and so they'll have them available if there's anybody else that you know might need one. But you can get them all off the Alliance website too if you need any more. Yeah, absolutely.